President Biden once again isolating at the White House after testing positive for a rebound case of COVID. The White House physician says the president, quote, continues to feel well, but is still testing positive. Let's bring in now Dr. Amesh Adalja, his senior scholar at Johns Hopkins University Center for Health Security. It's good to have you with us this morning. So when we look at this, I think it's interesting to note, too, as Jasmine just pointed out, there's increased testing cadence for the president. He's getting tested all the time. But it does seem like we're hearing anecdotally about more and more of these, quote unquote, rebound cases of COVID. Is that an issue with the disease? Is it the Paxlovid, or do we not know?
I think there's still more questions than answers. So there seems to be definitely anecdotal evidence that people who take Paxlovid, these high-risk individuals, have this rebound phenomenon. But is it because of the drug? Is it because of who's getting the drug? And when you look at the clinical trials, Pfizer says it was not more common versus the placebo. So this is something that really needs a lot more investigation to understand what's actually behind it. But the good thing is that people who get this rebound do really well, and it's not a reason not to take Paxlovid if you're somebody who qualifies for it.
Which I think a lot of people are asking, so thank you for answering that question before I even asked it. There's also, I've noticed there's been some talk about whether perhaps it should be a longer course of treatment. So it's currently 5 days, whether it should be increased to 7 or 10 days. Is there any research that would support that at this point?
None, but this is something that we want people to actually do studies to determine, because this rebound is distressing to people. Those people may be contagious. So if the longer course can prevent that from happening, it might be something to do. Although the taste is bad, so people may not want to take it that long. Mm-hmm. But if it's something that has a clinical benefit, then I think we should be trying that, and I think that's what we should be studying.
Yeah, there's a lot of medicines that don't taste great, but they sure work well. So that's the important thing, right? I also want to talk to you about monkeypox. So we're talking about it a lot, obviously, here in New York City. Public health emergencies have now been declared. San Francisco is the first major city to do that on Friday, I believe it was. There's also a push for more from the federal government. Why is it so important that this be labeled a public health emergency?
What we've seen through this monkeypox outbreak in the U.S. is that bureaucracy has gotten in the way of doing what's right. We have 120-page documents you have to fill out to give antivirals. Very difficult to get vaccines. Testing was a disaster, just like it was for COVID in the very beginning of this. And what's happening is we see them talk about constraints that they have, but these are all government-induced constraints. And what we know is that states of emergencies streamline that. They get rid of all that bureaucracy and red tape that probably shouldn't be there to begin with, and that may be the only way to go to actually get the government to be responsive to what the people need.
What's interesting, too, is we saw the WHO, I believe it was last Saturday, so more than a week ago, declared that this was a global health emergency. Some of their messaging has been a little bit more clear as opposed to what we're seeing here in the United States. How much do you think that bureaucracy is also playing into the confusing messaging?
I just wonder, after 2 successive administrations where the CDC has sort of been compromised in terms of its ability to talk to the general public, that there's political considerations that go into their messaging. Things are getting vetted by political appointees rather than actual people who are subject matter experts, and that may be why you see this mixed messaging. But we definitely need to talk to the public generally about what the risks are, what they aren't, and I think it's kind of sad that this is happening after COVID-19 when we got so much wrong, that this should have been kind of a layup, an easy infectious disease that's not that contagious, for which we have a vaccine, and we're fumbling it.
And a disease that we know a lot about, right? It's not new. It's not a novel coronavirus. Monkeypox has been around, to your point. Right. So we know what the treatment is. We know what the symptoms are. You were talking, too, I've read in some of the articles you were quoted talking about, we need a broader vaccine response. Would declaring this a public health emergency, which would then require, as I understand it, sharing some of that vaccination status and data more broadly, would that help?
I think it would help to understand how people are getting infected, who's getting vaccinated, where the gaps are in that risk group that aren't getting vaccinated. And I also think we need to think about prioritizing first doses like they're doing in New York, and even thinking about older smallpox vaccines for people who qualify for them, who don't have risk factors for side effects. I think we have to have kind of all stops pulled out to try and stop this, because this is something that can be stopped and should be stopped.
Yeah. Doctor, great to have you with us this morning. Thanks for coming in.
Thanks.
Appreciate it.